Good afternoon, everyone. Thank you very much for joining this session. This lecture series aims to foster a spirit of innovation and entrepreneurship among our learners. It's my great pleasure to invite Dr. John Ainsworth, who is a professor of health informatics at University of Manchester, and he's going to talk about what role will data and digital technologies play in the future of health and healthcare. Thank you, Dr. John, and appreciate your time today. You're mute.
Thank you, Sadiq. I'll just share my screen and I'll start my presentation. Okay, thank you very much. And thank you, Sadiq, for inviting me to give this seminar this afternoon. And indeed, I will talk about the role data and digital technologies will play in the future of health and care. And I'm going to start by looking at some of the challenges and some of the history of digital transformation in health and care. And then I'm going to project forwards into the future and think about what the future of healthcare might look like. So just a little bit about me. I'm a professor of health informatics at the University of Manchester in the UK. And I'm also the head of division for informatics, imaging and data science. And so my department is very much engaged in the digitization of health and care and also health data science activities, really bringing the digital and data element into health and care. So I'll get started. So my field is health informatics, and I like to describe it or define it as this. I broadly break it down into three different areas, which are systems, algorithms, and people, because actually these all play a significant role in the delivery of health and care. So people might be the obvious one because people are the recipients of health and care, but actually increasingly they're becoming more of a participant rather than just a passive actor in health and care. And so some of the technologies such as wearable sensing, smartphones, where we actually start to collect data from people, are making a significant inroad into this. But there's also as well the aspect of how you change people's behavior as well. So, for example, we think about what are some of the most prevalent impacts or risks to your health. There are a lot of things around lifestyle, whether it's diet or exercise, where actually behavior change becomes increasingly relevant to actually steer the correct behaviors. Historically, we may think of health informatics potentially as systems, so electronic health records, clinical decision support, remote monitoring. And so, yes, that is an absolutely crucial part of it, because the digitization and deployment of systems into health and care enables us to actually take a more data-driven aspect to this. And when you've got a data-driven aspect, it brings into play the third aspect, which is algorithmic healthcare. And with algorithms, we're really thinking about how we can make healthcare more predictive, the whole idea of precision medicine, being able to understand an individual's risk factors for a particular disease, but also being able to understand potentially treatment response at an individual level as well. And also within the algorithmic space, obviously we have text analytics, image analysis, and these days this is commonly generally defined as AI for healthcare. So this is the kind of space that I operate in. And I think as I hopefully develop through the course of the talk and explain how this will actually really change health and care. This is an interesting report, and you'll see the link to it at the bottom of the slide, that the King's Fund, which is a UK-based health think tank, essentially, produced that and it came out, I think it was in 2019. So it's about 5 years old now, but they looked at what they thought would be the technologies that will really impact on healthcare. And what's really interesting about this is actually nearly all of these technologies, with the possible exception really of smarter implantable drug delivery mechanisms and portable diagnostics, are really data and digital based. So we have the smartphone, digital therapeutics, genome sequencing, machine learning, which again often called AI these days, blockchain, and actually the connected communities are actually where things are all joined together. So it's, I think, very much the case that these are the technologies that are starting to have a direct impact on health and care. And probably the only one I'd probably disagree with a little bit here is the blockchain aspect, but who knows? Maybe in the future someone will find a good use for blockchain. So why does this matter? Well, we actually struggle quite a lot in health and care to understand the lifetime trajectory of healthcare. And this is the very simplistic view of dementia trajectory, but it's here to make the point that over the course of the lifespan, your cognitive function is going to be affected by various different things. So obviously, your genetic genome plays quite an influential role in this. But over the course of your life, while you're healthy, there's various different lifestyle factors that could play into this, including exercise, including things such as diet and smoking, exposure to environmental toxins. And these all kind of interact over the life course and the lifespan. And as you get towards the end of your life and potentially a diagnosis of dementia, then other things come into play, such as vascular health, protein aggregation, synaptic health, immune function, and neuronal loss, which all give you this rapid decline in later life of cognitive function if you're diagnosed with dementia. So looking at this, you can see that actually all of these things are important and they all interact with each other, but actually how they interact, so how they cascade, what the time order of them, how it varies from person to person, it can be different and we can't assume linear relationships there. So I suppose the message I'm trying to give you here is actually, this is actually a very complex picture, and how we actually go about untangling it requires a different approach into actually treating an individual as themselves and actually monitoring over the life course an individual's health and exposure and continually updating the potential risk. So just to think about how we might do that kind of thing, well, we now have technologies that can do this. So we have the wearable technology, we have smartphones, we have devices that can measure medication to adherence. And actually, what happens in between the provision of healthcare? So you think about how we provide healthcare. Traditionally, somebody who has, for example, a long-term condition, maybe some kind of respiratory complaint, will go and visit their physician and set clinic visits, which are maybe weeks or months apart. But we actually have very little idea of what's going on in between in traditional healthcare. But actually, with these technologies, we can actually start to do continuous monitoring of that individual. And if we have continuous monitoring of an individual, we can then start to think about how their disease fluctuates and changes and whether there are rhythms in this, and how we can actually use that knowledge to actually drive towards a precision medicine future where actually we're able to take an individual and look at what would work best for them at any particular moment in time, And this brings in kind of, if you like, the concept of the health avatar, which is like a model of an individual that understands the rhythms of their diseases or models the rhythm of their disease and their exposure, and can start to give advice and really personalize the treatments that individual. So this is where we're heading. And one of the problems that we have in moving to this vision is that the way healthcare is organized, we actually treat individual diseases rather than individual patients. And this is fine if, for example, you only have diabetes and that's your single complaint and you can treat diabetes. But actually, of course, what we find, particularly as you age, there are increasing number of comorbidities. And yet the health system is organized to treat these individual diseases, whether it's be, for example, asthma or some mental health complaint, in isolation from each other. So we're actually treating individual diseases and not the patient themselves in the round. And there's a very good reason why we don't do this, and it's very similar to what I said in the previous slide, is actually we don't really understand how these things, different diseases, interact and how treatment decisions for treating one really impact on the other. And there's a stunning, I think, number that actually what we know from medical knowledge, we're only really have the evidence to predict about 30% of the outcomes in any given healthcare scenario. So there is this big evidence gap as well that we need to fill. And my contention is that data and digital is the way we will fill this evidence gap. So just moving on to think about where we are in terms of a data landscape in healthcare. So if we start on the left of this slide, we have traditional research data. And this is really the gold standard data in healthcare and defines the knowledge we actually know. So of course, randomized controlled trials are the gold standard for understanding which treatments are most effective. But also we have the more case control studies and the cohort studies that give us insight into disease in populations. Over the course of the last 20 years, omics data has become more prevalent with genome, proteome, and all the other omics that you can think of, also providing us insight into in essence, I think in some cases, the genome data, the starting point of an individual's lifetime risk for various different conditions. Similarly as well, routine care data is now much more prevalent as well. So this is the data generated as part of providing healthcare. So it could be disease registers, administrative data, or indeed electronic health records. And typically this will provide the history of an individual and their medical history. When we move more now to the new types of data, so we have home-based sensors potentially, such as blood glucose monitors, blood pressure, or smart scales. And as I've mentioned, we have smartphones, which we can use for self-report symptoms, tracking behavioral patterns, so the places you visit, which can provide insight into some conditions such as prevalent mental health. And then we have also wearable sensors, so really now starting to become quite sophisticated, being able to provide anything from the physiological measurements of skin temperature, heart rate variability, and to simple ECG applications as well. So the picture is very much changing in terms of the data that we have. So I want to step back a little bit before we get too excited and just look at a brief history of digital transformation in health and care and look at some of the technologies that have delivered this digital transformation, but just tease out how long it takes from the technology being invented to actually being rolled out into practice. So if you think back to the 70s and actually probably the late 60s, we had the first AI systems or clinical decision support systems that became quite widely known. So we have MySyn, which was a clinical decision support system for understanding the different potential bacterial infections. And we had ELISA, which was the very first chatbot, I think, that was replicated the capabilities of an online of a therapist or a psychiatrist. So these things have been around for a while. In the 80s, what we saw emerge were terminology systems for coding medical data and the underlying ontologies that support this. So you think of something like SNOMED clinical terms. This was the genesis of those things back in the 1980s. 1980s as well also saw the introduction of magnetic resonance imaging, MRI scanners. Then in the 90s, I think we had the technologies that enabled telehealth, so remote communications, networks of sufficient bandwidth to enable both data transfer and video communications, alongside, I suppose, the birth of the internet. But then also in the 90s as well, we see the introduction of electronic health record systems, which are strongly dependent on terminology systems and clinical decision support. And so you can see there's already a lag there between the invention of the technology and the delivery of it into practice. In the noughties, we started to have standardization and interoperability between electronic health record systems and telehealth systems. And also MRI imaging became a normal part of the diagnostic toolkit for healthcare. Also in the noughties, on this trajectory, we saw the development of deep learning and smartphones, the technology. So deep learning, if you're not familiar with it, is the underlying methodology of large-scale AI that is so prevalent these days. And in the tens, what we saw starting to engage patients in healthcare through joined up care records with patient portal access. Then also in the tens, we saw the introduction of wearable devices and also actually the development of prediction models or diagnostic models that have human level performance. So really actually developing those AI technologies that can look at an image and diagnose from that image just at the same level of performance that a human expert can. And that directly leads on from the deep learning technologies. And then more recently, bringing us up to date in the current decade, we have large language models such as ChatGPT, which is the next evolution of the AI model. And then also within the last 5 years or so, we've really seen these kinds of technologies become more commonplace in healthcare. So telehealth or care, virtual wards, remote monitoring, and digital therapeutics. And the message I think I'd like you to take from this slide is actually there is a significant lag between the technology being developed and it working its way into practice in healthcare. There's an often quoted number for the time it takes for a new medicinal therapeutic to make it into practice, which is generally given us 17 years. Actually, looking at this, the adoption of technology into practice seems to operate on a similar timescale, maybe slightly faster, but it is quite similar. So then we think about the ecosystem of digitally enabled care, and within this, we're really thinking about how the patient actually becomes an active participant in their health and care, and is part of self-management, leading to predictive care support, ideally leading to better outcomes and lower health and care costs. And you can see the different technologies that form this ecosystem, from monitoring systems of physical health, monitoring systems of mental health, algorithms that alert potential risk of relapse, remote monitoring technologies that enable us to see an almost continuous picture of an individual, telehealth solutions that foster that connected community of care, electronic health records, of course, and incredibly important for understanding what's going on, but then also some digital therapeutics such as apps and VR, which are now starting to emerge. And then, of course, medication still plays a significant role, but actually personalizing the different therapeutics and maintaining adherence is incredibly important. And then I like to think of this all within the context of P4 medicine. So if you're not familiar with the concept of P4 medicine, I think this is the direction that health and care needs to go in, and it presents a nice organizing framework for actually what we need to do for the next wave or revolution, if you like, in healthcare. And the P4 medicine approach stands for predictive. So actually using data and digital, can we predict early enough that there's disease or your risk of disease? And then can we link that to prevention? So if we can predict something, is there something we can then do to prevent this? It also needs to be participatory. So I spoke a little bit before about healthcare being done to people, and people are passive recipients of healthcare. Well, in the future, actually, people will need to play a more active role in self-managing their own healthcare. And then personalized as well. So actually understanding the individual, understanding their different diseases, how they interact, understanding potentially their treatment response to different medications. So actually we can deliver the correct medication. And I think if we can move towards a P4 medicine future, then actually will enable us to keep the population much healthier for much longer. So just drilling down a little bit into what I mean by precision medicine, I like to think of it in terms of 4 different models. The first one is a disease risk model. So how likely are you to develop a disease? So this will be based on a number of different factors, including your genomic makeup, but also your lifetime exposure, your lifestyle habits, and this will change as you age and as you have more exposure, or in terms of having more exercise. Then we get the diagnostic model, and this really asks the question, how likely are you to actually have a disease? And this will be based, of course, on different phenotypical characteristics or biomarkers, or increasingly in the future, digital biomarkers. And if you are diagnosed with a disease, then the next step is the prognostic model. So what we want to know is what's the likely outcome of that disease for you as an individual, and how will that affect your future health? And then finally, the 4th model is treatment response. What we really want to know is what's the best medication for you, or the best intervention, because it may not be medication. Excuse me. So how likely will you be able to respond to a particular treatment? So with that framework in mind, I'm going to give you an example of some of the research that we've been doing in Manchester over the course of, well, actually probably started around 2010. We've been very interested in schizophrenia. So schizophrenia is a serious mental illness characterized by periods of relapse into psychosis. And the pattern of this relapse into psychosis has been known for quite some time. So this is from a paper by Bastillo in 1995. And it illustrates the potential trajectory from somebody with schizophrenia up to relapse into psychosis. And what you can see from the baseline on the left, an individual will be subject to some kind of stressor and enter potentially the prodromal phase of psychotic relapse. And you'll see here that the arrows coming up from the bottom, particularly personal coping, but early intervention treatment can actually avert the full relapse into psychosis. So this really begs the question, though, is how do you identify that prodromal phase? How do you identify when early intervention treatment will be effective in avoiding relapse? And this was the starting point for some work that we did using smartphones for continuous monitoring of people with schizophrenia, combined with a prediction algorithm to predict relapse into psychosis. We, as I said, we started this work in around about 2010. And this is the publication from 2022, the Empower trial. It was published in the Lancet Psychiatry. And what we demonstrated with this approach of continuous monitoring and a prediction algorithm using that data from the monitoring, we were actually able to reduce relapse by about 50% in the active arm of the trial, which is quite a significant result. We're also able to show as well that from a health economic analysis, that this actually reduced the healthcare costs, because what actually drives healthcare costs in schizophrenia is inpatient treatment if you have suffered a psychotic relapse. So if you could avoid that relapse, you reduce hospitalization, and therefore you get better outcomes for the patient, but you also reduce the costs for the healthcare provider. So this is a really good example of the kind of thing that can be done with these technologies and prediction algorithms driven by data. So we're now in the next phase of this work. So we have a new study called Connect, which has been funded by the Wellcome Trust, which takes the base of the Empower study, but now we want to actually dig in a bit deeper into what are the predictors of relapse in schizophrenia. And what we're doing is running a large prospective cohort study of 1,100 people, and we're characterizing them using smartphones and wearable devices, and we are capturing passive data from them. So this is data that the smartphone itself generates just through your patterns of interaction, or potentially through the GPS or other sensors on the phone. And so we will have behavioral insights, patterns of behavioral insight, and also physiological data from the wearable device. And what we're hoping to do is to be able to build a more accurate, more reliable prediction model that actually doesn't require any input from the individual, because we're just using completely passive sense data. So we'll actually minimize the burden on the individual and maximize engagement, because really all you will hopefully need to do is wear a wearable device, and it will be able to predict when you're approaching psychotic relapse. So that's the next phase of this work. We've just started recruiting our participants into that cohort, and this will run for another 4 years. So just to go through some of the data we are collecting in this study, you'll see on the left is the smartphone. You'll see the right is the data collected by a wearable device. And these are consumer grade wearable devices as well. So we're using Fitbits and Apple Watches, but they give us a good signal within the individual. And some of the behavioral data that we're able to collect as well include things like the number and length of phone calls and number of text messages sent and received, patterns of speech, patterns of movement, light levels. And so some of the things we're able to collect via the wearable include heart rate and variability of heart rate, skin temperature, sleep, and of course, activity and step count. So I'm going to change tack a little bit and look a bit more to the future here. But first, I'm going to give you a definition, or a very simple definition, of machine learning. So machine learning, also commonly called AI these days, but it basically works like this. So you have some kind of machine learning algorithm, and you have some kind of data set, and it will produce a model for you. And typically these models will be the prediction models. So you'll be able to predict, for example, a risk of developing a disease, a classification model. So you'll be able to identify some particular feature in some kind of medical imaging. Clustering algorithms, where you're able to sort people into similar groups. Or increasingly, we have generative algorithms that are actually able, given certain prompts, to create new content. And these generative models are what are termed large language models. And so essentially just sticking with the scheme that I presented before, the algorithm in this case is something called a transformer neural network. The data that they're trained on is, in the case of large language models, typically the whole of the internet. And what it produces is this large language model, also known as a generative pre-trained transformer, which is where you get the GPT bit of, for example, Chat GPT. And there you have example of Chat GPT. Just looking at these large language models and why are they so interesting? Well, actually, they're extremely complex. And as I said, if you look at the training data on the right, and there you've got the sources that they've used for ChatGPT. So they've crawled the entire web archive, something called Web Text 2, Books 1 and 2, which are digitized collections of books, and the whole of Wikipedia. And what they do is they use this data and feed it into the model, and that creates essentially what they call a foundation model. And from this, then there's a process of refinement, where you actually tune the large language model to be able to do something that is a bit more domain specific. And some of this involves reinforcement learning from humans, but also what's known as adversarial training, where different models compete against each other. And you use this, and you eventually you'll move towards essentially what is a domain-specific model. And one good example of a domain-specific model is the Palm model from Google, which was specifically created to encode medical data and respond to medical-like questions. And they've actually tested this on MedQA, which is a set of questions or exam-style questions that follows the format of the US medical licensing exam. And they were able to demonstrate that this particular model could achieve almost 68% accuracy. Then when they've done this again with MedPalm 2, it achieves an accuracy of 86.5%. So these things are actually in this domain are actually starting to outperform humans in terms of their ability to respond to a question and give the appropriate response. So actually this field is also moving very, very fast as well. So this was published in July 2023. I'm sure by now that the performance of these things has exceeded this. So one of the things that I always come back to with any particular healthcare technology, and this is the standard health technology assessment framework, is we're always looking for these technologies to be both efficient, so that they are cost effective, so we want to know that they actually work. We want to know that they're safe, so they don't harm patients. They also need to be acceptable to patients as well. And we also look for equity as well. So there is no distinguishing or inequalities introduced by these technologies. And if you think about this in the context of a particular AI model, there are questions we really, I think, we should be asking. So, for example, we need to understand how much trust do we have in AI? Who made it and why did they make it? Is it fair? And as part of asking the fairness question, is there any inherent bias in the training data? Because all these models are only as good as the data that is used to train them. And if there are inherent biases in that training data, then the models themselves will be biased as well. We also want to think about when mistakes are made. Who is responsible? So some of these things are clearly providing a certain degree of autonomy of decision making. So we need to ask what are the acceptable error rates, and we also need to understand how these things might form chains of reasoning and understand at which point of the chain something may go wrong. We also need to think about these things as well as adaptive systems. So often in health technology assessment and looking at safety of systems or medicines, they don't change. But by definition, some of these AI technologies do change over time. They're adaptive systems. So how can we ensure that they remain safe when they're going to, by definition, change? So we haven't really, I don't think, understood the nature of these adaptive systems and what it means for safety. Acceptability. So a lot of these technologies, particularly the deep learning technologies and the large language models, are essentially black boxes in that we don't know how they work, or they can't show us how they've reached a particular answer or a particular conclusion. They're not inspectable. And so we need to really grapple with this as well and ask the question, is this actually really acceptable? So they may have very good performance, but does it matter that we don't know what they're actually doing to deliver that performance? And then finally, equity. And the question really here is, so these models require large amounts of data. This data is essentially from a healthcare context. It's from all of us and our healthcare histories. How can we ensure that actually we all benefit from this data that's used to train these models? And this really speaks, I think, to the notion of benefit for everybody. Obviously, commercial companies are very active in this space, but how can we make sure that when they're using data from all of us, that actually we all benefit from this? So I'm going to use the remaining time of my talk now to look ahead and see how all these technologies may come together within the future. And I'm going to start by thinking about the notion of the digital twin. So the digital twin was really a concept introduced by NASA as part of spaceflight engineering, essentially. And the concept of a digital twin is to create a model of something that exists in real space, in virtual space, and use that model to predict what's going to happen given exposure data from real space into virtual space. So with that, you can compute using the model whether something's going to change, whether something's going to break, whether a component is going to fail. And then you can feed that information back into the real space and maybe take some action to prevent that failure. So given that model, that does sound very similar to the kind of model I was talking about before in terms of the P4 medicine space. So basically feeding exposure data from a real environmental space into a model, using that to predict when an adverse event or something might happen, and then feeding that so action can be taken to prevent that. And you'll see that's very similar to the P4 model. We can extend this digital twin concept to that concept of an individual. And this is where we tie back to the digital health ecosystem, the emergence of data collection almost continuously from an individual via those wearable devices, via those smartphones, via Internet of Things technologies based in the home, and various other sensors. These all feed back real-time information about an individual, about their exposure. And if we have this digital twin model of an individual and it's seeded with data from, for example, your individual genome, this starts to personalize it towards you as a model, but then also the continuous feeding of data about exposure enables us to really personalize that to an individual and predict these insights and feed those back into the individual and help them with self-management of care and better decision making. And as you can see, this very much fits into that digital health ecosystem that I was spoke about earlier on. In terms of the technologies that we would need to do this, now exist for the data collection. And if we think about this as well, so not just on an individual basis, but if we think about scaling this up so that you can imagine a world in which each individual has a digital twin that represents them. And so you have the entire population represented by a digital twin. Each one is actually unique and each one represents an individual's personal health trajectory. And so essentially what we're doing here by creating this kind of model is starting to encode in a lot more detail, actually a very rich picture of what happens to an individual, what interventions are tried, what the outcomes are, and essentially we have a full trajectory representing an individual person's health journey. And if you think back to the slide at the start where we had that trajectory of dementia, well, we're now starting, or potentially we could start to untangle that for each individual one and generate insights across the population. So this then brings us, I think, to really where this could go in the future. So if we think about large language models and digital twins, well, if I ask the question that if we use transformer neural networks and then data from a population of digital twins, which remember are sequence data representing life trajectories, what would we actually get from this? What would that actually produce? I should say that actually, although we have the transformer neural networks, we don't quite yet have the data from a population of digital twins. But if we did have this, essentially what we'd be able to produce is essentially a predictive model of healthcare that could, given any particular input from any particular digital twin, encode the data of all the other digital twins and deliver the future of healthcare for us. So I've now reached our conclusion. I'm just going to summarize. So what we see very much is that methodological development, particularly in the space of machine learning and AI, is very rapid, and it is almost changing on a daily basis. So we're getting much more sophisticated in models and methods that are producing ever sophisticated models that will lead us towards the digital twin with ever increasing computing power. What we don't have yet is the linked patient level multimodal data at widespread scale that you would need to build the digital twins. But this is now starting to emerge. We also note that digital technology adoption is slow, but the counterpoint to this, I think, is Amara's law, in that we tend to overestimate the effect of technology in the short run, but underestimate the effect in the long term. So although we're still some way off developing the digital twins, having the data to feed them, I think in the long term, this is probably the direction that we will go in. And with that, I would like to say thank you for your time and attention today. It's been my pleasure to speak with you, and I'm happy to take questions.
Thank you, John. That was an excellent talk, actually. And I will first start off with the questions from the audience. Uh, so first question is, clinicians don't like or trust black boxes. So I think so. Maybe the questionnaire, the person putting the question is, how do we start trusting these algorithms which are being developed? If you think about healthcare, it is just delivering different algorithms, but replacing the tried and tested algorithm with an AI algorithm to do the job, routine job. I think that's what the I think Dr. Goel is asking. So maybe your thoughts on that?
Yeah, I mean, so I referred to this in one of the slides about acceptability. And I think there's probably, and this is still, I think, a matter of opinion and debate, there's probably still an inflection point where things are demonstrated to have great utility, but operate as a black box. And there's a balance, I think, to be made between that utility and the ability to understand how decision is making is made. But it also, again, comes into the concept and the notions of safety and bias within those things. And it may be okay for things to act as a black box, and we may accept that if we have some certain guarantees around how they were created, who created them, and what their performance is. And I don't have a definitive answer for you here, because I think this is still very much an emerging area where more research is needed.
Thank you very much for that. I think so. The second question you kind of answered in a way, like genomics and its applications with the digital twin answer. But maybe if you have any more thoughts on that.
Sorry, what's the question, see?
Genomics and its applications. I think so with the I think you answered that in a way with the digital twin concept.
Yeah.
But
Yeah.
any
So,
more?
yeah, genomics, a very important part of this picture. So I like to think of it like this. So your genome is your starting point for your particular healthcare trajectory. So it defines for you at the start of your life potentially what some risk factors are for different diseases. These risk factors get modified over the course of the lifespan. By your exposure to environmental pollutants, to the lifestyle that you live in terms of exercise and diet that modify these things. But some of them as well, maybe hard constraints or hard risk factors for different diseases that are not modifiable as well. So it really is an important part of building this future of the digital twin, that actually the fundamental core part of the model does come from the genome.
Thank you, Doctor. Then following two questions are for my learners. If I want to choose a career in health informatics, how do I go about that?
Excellent question. Health informatics has, I think, over the years suffered from the fact that it doesn't have a professionalized body behind it. But I think this is something that we've looked at quite a lot within the UK, and we're starting to change this and provide it as a professionalized career route. So, for example, we have training programs in health informatics and clinical data science just in Manchester itself that we deliver. So it can be quite difficult, I think, to understand where and how to get started if those actual career paths are not available. So I think it's, if I'm being absolutely honest, still a bit of a struggle. But the key thing I think is to get people excited about it and understand, hopefully what I've conveyed in this talk, that actually this will probably have the biggest impact on health and care over the course of the next 20, 30 years, or if you're just starting your career, over the course of your career. And so this very much is, I think, where change in health and care will come from.
I mean, this was a learning which I learned here, you know. I was brought to set up a transplant program, and for that, I had to create a funnel for the patients to come through. I mean, Manchester, where I started my training, where who you work with, my ex-boss, Titus Augustine,
Yeah.
they had set up a system a long time ago. I was a cog in the wheel, you know. I didn't realize that how you have to bring the patients to the clinic, and for that, you have to understand informatics. The second question I wanted to ask was, it's a good segue. I mean, you have a background saying Manchester University was started in 1824. So these are institutions where you have multidisciplinary universities working together, like Titus works with you. And here, unfortunately, we have centers of excellence, but they're all not linked like what Manchester University has. So where do I go and meet folks like you who can help me develop programs for my specialty? And this is a question for my learners, you know. So where do I network with people like you who can help me be a better doctor?
Yeah. Uh, so I think the model we have in Manchester is really works really well. So I'm actually so I'm a professor of health informatics, and in some ways I'm really an applied computer scientist. But I don't sit in a computer science department. I actually sit in the Faculty of Biology, Medicine, and Health, and therefore I'm embedded with my clinical colleagues. I have strong links into the hospitals that generate the problems, and so I think this embedding works really well. Now, obviously, that's great for us, but it doesn't apply necessarily to other specialities. But I think if you want to try and build this model, I think recognizing that informatics, data science is a core part now of medicine, clinical medicine, and it's going to be increasingly so. And faculties, I think, need to adapt to do this. And I think also hospitals and health systems need to recognize this as well. So what we see quite a bit of now in the UK is the establishment of clinical data science units within hospitals themselves. And these are specialist groupings of clinicians and data scientists that can come together and solve some of these challenges. And certainly that's one model that I think works quite well. And that in that model, we're actually, my academic colleagues actually go and sit in the hospital and work on these kinds of problems. So you can build some kind of model like that. Of course, if you're in the interested in the general area of health informatics, there are numerous different conferences, academic conferences that bring together a community of people like myself and clinical researchers. Perhaps the best known one and the largest one is the Med Info conference, which is held every 2 years.
Thank you. That's a beautiful talk, and I enjoyed listening it again, and I learned more. And I think the whole idea of these lecture series is to invite folks like you so that we can understand your language, understand what you're working on. Because in healthcare, I'm only teaching people, my learners, how to look after the patient in front of them. But when I became a consultant, I realized I'm solving larger problems, system level problems, where unless I understand technology and how I can leverage it, I cannot move care forward. And I hope the audience loved the talk like I did. And thank you, John. And hopefully you can collaborate more in the future. Thank you very much and have a
Thank you.
nice day.
Thank you, Sadiq.
Thank you. Bye bye.